So I'm going to introduce myself because Elaine's gone. I'm Allie Kempe. I think I know everybody in this room, so we don't need to go any further. So I just wanted to mention that this is the last in our regular series of CRISP seminars. And then we're going to have the Pragmatic Trials Workshop in September, and this is actually already fully enrolled, and we have a waiting list. So if any of you are not enrolled, you can get on the waiting list, but there's obviously a lot of demand for this. We're also going to have, we hope, an mHealth Tools and Strategies Workshop in October, and that is not completely full yet. So if any of you are interested, the email is there, or the website is there. And then in the fall, we're going to have a whole new seminar series, we hope. Okay? So if you have ideas for things you want, let me know. All right, so I was going to talk about a few studies we've done, mostly under the CRISP umbrella, about how to increase immunization rates for populations of children. And we're going to look at a few novel approaches. So there are some underlying principles I want to set as we go forward with this. These projects focus on entire populations rather than exclusively focusing on who makes it into the practice setting. And that's a very important underlying principle. Another important principle is that the projects involve collaboration between primary care and public health as a central component. And that's, I think, extremely important as underlined by the Institute of Medicine's report that came out a year or two ago. And the projects I'm going to talk about emphasize feasibility, efficiency, and cost effectiveness in order to keep them sustainable. So these are some themes I'd like you to listen for while we're going through this discussion. The importance of input from the relevant communities that we're trying to serve here, the importance of this collaborative approach, concepts of efficacy versus effectiveness, which I'm going to highlight, the importance of reach in measuring implementation effectiveness, which is key to the proposal I'm going to present, considerations of cost for sustainability, and basically also how lessons we've learned with young children can be translated to other populations and how we're thinking about doing that. So, first of all, interrupt me at any time. This is a small group, so we can go wherever you want to go. Okay, I have too many slides to present, so we won't ever get to the end. So I don't think I need to tell many of you in this audience about the importance of immunizations, which have been highlighted as second only to clean water. And on the right here, you see the percent decrease in all of these infectious diseases. And here it is graphically from 1950 to 2010, and you can see that most of these diseases have been largely eradicated, or not eradicated, but they're at very low levels, with some exceptions that we're starting to see some breakthrough of measles and pertussis, largely because of failure to immunize. So how are we doing right now? Healthy People 2020 goals are 80%, and we're somewhere in the high 60s. So we have a ways to go. The Community Preventive Services Task Force recommends ReminderRecal as one of the most evidence-based strategies for increasing immunizations for children. And this can be the use of mail, phone, email, or text to remind parents of upcoming immunizations or recall them for overdue immunizations. There have been, I think, 40 trials that have been conducted in practices showing that if practices do ReminderRecal, it increases their immunization rates to the tune of 5 to 20%. However, this is very difficult to implement even within highly motivated practices that have access and know how to use an immunization information system, or IIS. And currently it's estimated that only about 16% of physicians nationally are doing ReminderRecal at the practice level. So data from our group and other groups have demonstrated that there are multiple barriers to doing this, and I'm just highlighting 3 of them here that are the most commonly mentioned. Competing demands is huge in primary care, as all of you know. Lack of personnel that are trained to do this.
lack of expertise with both the IIS and IT systems that could be used, and cost. So we, a number of years ago, reasoned that ReminderRecal conducted centrally by public health departments could reduce this burden on practices and could reach children that were not accessing primary care practices while hopefully maintaining the central role of primary care home. So the overall aim of our projects was to increase rates in populations of children before they enter kindergarten and to answer some research questions that were important both locally and nationally. Dominantly, is IIS-based recall more effective and cost-effective if conducted centrally or within the practice setting? Is centralized IIS-based recall more effective if done in collaboration with the practices, so both entities working together? And is this centralized approach acceptable to providers and families? So those are the questions I'm going to try to show you some data about. So the first one is a pragmatic comparative effectiveness trial directly comparing two methods. So our objectives were to compare effectiveness and cost effectiveness of ReminderRecal in 19 to 35-month-old children at the population level. So our aim is to increase immunizations population-wide using two approaches, either a centralized collaborative ReminderRecal approach. So this is an approach in which the state health department, using the IIS, collaborates with practices to do this centrally, or a practice-based ReminderRecal approach. And then we had a secondary objective within the centralized ReminderRecal counties. We wanted to compare effectiveness within practice that chose to include their name on the recall letter, postcard, or autodialer, which we're going to call practice endorsement, and those that did not. So the populations were all children 19 to 35 months who are not up to date for immunizations according to CIIS in 15 Colorado counties. And these 15 were selected out of the 64 Colorado counties based on some inclusion criteria, mostly having to do with them not being too small and them having adequate saturation of CIIS, because we obviously didn't want to include counties where, and there are not many of these, where they were not using CIIS very much. So the randomization procedure, first of all, we stratified into urban and rural, and then within these strata, we used something called covariate constrained randomization to optimize the balance between the counties with respect to a number of variables that also can obviously affect immunization status. And the most important ones were the percent within this age group that were up to date at baseline, percent minority race and ethnicity, median income of the county, the percent of kids who were in the registry with 2 immunizations or more, the number of children, so total populations, the characteristics of the types of providers in that county, and the number of community health centers. So quite a few variables. And here's how you do covariate constrained randomization, and nobody's allowed to ask a question about this because Miriam's not here, okay? So basically you take baseline data on relevant contextual variables, and you then designate a balanced criteria, which is defined as the sum of square differences between study groups on these relevant variables. You calculate this for each randomization, and then you determine the criterion for maximal, you decide a priori a criteria for maximum allowable differences between the study groups established, and a set of acceptable randomizations in which these differences, the differences on covariates are minimized. Okay, so then you generate these and you decide which is, one randomization or one or two come out as the acceptable randomization. That's all I'm going to say. But it's a pretty fancy technique for if you've got enough groups and you've got a lot of things you need to balance on. Okay, so here's how this came out. We had 15 counties, 7 urban, 8 rural, and they were randomized within the practice or centralized ReminderRecal arms. Here's the counties, with the green being the population or centralized ReminderRecal, purple being practice-based. So denominating the study populations across an entire county is very challenging because, as you can imagine, there isn't a single source of data that's perfect. But fortunately in Colorado, the IIS is automatically birth certificates are automatically uploaded to the IIS, so everybody gets in the registry after birth. So we use that as our denominator in all counties. Now that's imperfect because some kids will move in, some kids will move out of the county, but basically that's pretty balanced. And if you're randomizing counties, that wiggle room should be balanced between your arms. So we downloaded from IIS the names and addresses of children in that age group that appear to need one or more immunizations. So we involved the community, but the community here was complicated, right? There were several communities. There were providers that are the ones providing most of the immunization. There was the public health department that is also involved in immunizations, and then there's the parents of all these children. So we did structured interviews with providers, parents, and public health officials to sort of inform how we were going to create a collaborative element. We then had a collaborative intervention advisory committee that was composed of these three entities to help us design whatever collaboration we could. And then we had a community advisory committee that was there to review outcomes and aid in dissemination. So we did key informant interviews with 12 providers within certain strata, 12 parents, and then the Collaborative Intervention Advisory Committee consisted of 3 providers in leadership roles, 3 public health officials, and 3 parents, as well as the investigator team. That all sounded really easy. It was not easy, actually. But there wasn't a lot of collaboration that people thought would work. So the things that they came up with is this idea of endorsing or not, which the private physician could choose to do. And in addition, for practices that could upload data to CIIS, they could agree to update addresses and telephones immediately prior to any recall to decrease the number of bad addresses, phone numbers, and they could, on the practice end, make sure their data was as up-to-date as possible so they weren't incorrectly recalling people. So that's something that they could collaborate with CIIS about. And on the back end, when telephone numbers were wrong or addresses were wrong, offices could agree to manually try to update that information. So those were the collaborative elements they agreed on. So just to summarize what this looked like in the centralized collaborative recall counties, the state public health department centrally recalled children in this time frame. The notices included the county health department and state health department logos and the practice's name if the practice chose to endorse. And up to 4 contacts were made. 50% were in one of 2 different protocols, and I'm going to go over that in a minute because there's a separate trial sort of embedded within this trial to look at the different protocols. So here's a sample postcard. We did not say, Joe Smith is due for his DPT. We said your child is due for, if it appears that your child is due for an immunization according to our records, please call your primary care provider, or if you don't have one, go to the public health department. And some of them wanted specific clinic times and things, and we let the counties designate that themselves. Okay, in the practice-based counties, what did we do? Again, this is a pragmatic trial, so this is what is reasonable and practical to try at a population level. So what we did was we invited all practices in those counties to participate in web-based CIIS ReminderRecal trainings. So it was fairly easy. They just had to be shown how to do ReminderRecal using CIIS. We suggested the same methodology as we were using in the centralized counties, and then we said we will pay for it if you do ReminderRecal for this group of kids within that period of time. So statistically, we created 2 models to to assess the association between the intervention group and whether or not a child became up to date or received any shot during the study period. And we, of course, had to account for the clustered nature of the data, et cetera. We also did a cost assessment in the centralized counties. We could very easily look at the staff time for training and implementation, mailing and printing costs, and the time it took to update bad mail addresses. In the practice-based counties, we could tell when they pulled an IAS report to do reminder recall, so then we would call them and find out how much time they spent and what they did. Okay, so we were able to calculate their costs, roughly. So first of all, this is the importance of REACH in this intervention. Is this a pointer? No. Okay. Well, if you look at the blue piece of pie on the left is centralized reminder recall, okay? So 13% appeared not to have received a reminder recall notice, and 87% did. That's the amount of bad addresses or phone numbers we were able to get down to, okay? So 87% appeared to receive the reminder recall in the centralized approach. In the practice-based approach, 1% could have received the intervention because only 2 practices conducted reminder recall, bottom line. Yes?
Allison, during the course of implementation, did you have like systematic updates for the practices, or did you just do it once at the beginning and then let them fly with it?
No, we did it up to 4 times. Okay, so each time we were updating.
Your group with the practice or the practice to the individuals?
So you're talking about in the practice-based county?
In the implementation phase from your group to the practice, did you just do it once in terms of telling them this is what to do? Or did you
Yes.
monitor during the course and then give periodic updates?
We did. In the practice-based counties, we offered them training, and we actually offered them training each cycle. But and if I don't know how many people did training, guys. 15 practices did training, but then 2 of them went ahead to do reminder recall. We did not continue to say do it, do it, do it. We said, we continued to offer them training each cycle, but we did not remind them to remind their patients. So the biggest issue here is REACH, obviously. So this is the percent receiving any vaccine of those not up to date within 6 months, 27% in the centralized versus 22% in the practice-based. So the effect size was about 5%. This was less than the first time we did this, it was about 10% the first time we ever tried this. And we were starting with a higher immunization rate, so that's one of the issues. But it is kind of interesting that every time we do it, it's a little different, but this was lower than I thought. Percent brought up to date was 13 versus 9%. Now I'm going to show you that with, practice-based reminder recall works. It's not that practice-based reminder recall doesn't work. It works. So this slide shows that within practice-based reminder recall counties compares the percentage becoming up to date if the practice did reminder recall versus not doing reminder recall. So 29% versus 9%, huge difference. Again, you can't really say that, these are 2 practices that are unusual, okay? So I don't think that's a generalizable. Last time we did a study like this, it was still more significant than if you did it at a population-based level, but it was not this profound a difference because there's a huge bias in who the 2 practices were that did this.
Is that a fair comparison? You got 15 to say we're going to do this. Only 2 of the 15 actually did it. So, practice-based recall, should that number be 2 or should it be 15?
But they didn't do it.
Right, but that's the point. Mm-hmm. They didn't actually do it. Mm-hmm. So that difference there would not be 29 to 9. It might be much lower on the
You mean if the 15?
Of the 15, right.
Yeah, I mean, I guess the question is, from my perspective, what a pragmatic trial, this is a really interesting issue because we actually got reviewers who were arguing with us about, what should have been the denominator here, those that that did it, or those that were offered it, or whatever. So, from a population perspective, if you're a state health department and you want to increase immunization rates, you can try approach A or approach B, and the bottom line is, what's the rate here and what's the rate here, So I don't know if the 15 that got trained should be treated any differently because they didn't do anything.
But you went to the trouble of training them. They signed up, they got trained. So, I mean, overall, the difference between the practice-based recall with 15 versus up to date versus your population-based centralized approach is going to be even greater.
Yes.
That difference is going to be even greater.
Well, I mean, this will be, the 29% will be way lower because, yeah. So, I mean, bottom line, practice-based works. It worked a little too well here, I think, because you've got some really unusual practices, and that's way higher than it usually is when you do practice-based. But the bottom line is we couldn't, in what we thought was a reasonable and pragmatic fashion, motivate practices to do this, even with training and money. And now if you compare the costs, sorry, David.
One other way to frame that, and I absolutely agree with you, that from a population standpoint, is the unit of analysis the patient or the practice? Because what we were really trying to do here was change practice behavior in a sense. And if, in that sense, you weren't able to do so. I mean, you were able to change it in a very few. You were basically the early adopters, and you didn't manage to move up that curve into the sort of middle ground. That's a really important finding and a really important thing from a health department and from a population perspective to think about is what, as you're thinking about this. And this is the same issue that's going to come up when we talk about managing patients or children with special health care needs. Should we be managing them at the primary care level, or should we look at them at a population base across the state level and have statewide interventions to try and get them to access? Because it was still, I'm guessing it was still mostly the practices that gave the shots even when the reminders were coming from
That's right.
the health department.
That's right.
Right.
Yeah, I think it's a very important issue, and there's other issues we can talk about in terms of how do you better motivate practices, and different types of intervention are much more likely to be uptaken, I think, than others. Here you've got something where there's a high degree of IT, really. I mean, this can be done efficiently and effectively in a centralized way. It's far more difficult to do with every practice solving their IT problems. The example you brought up, children with special health care needs, I don't know whether that's going to be.
Nor do I.
Yeah.
Only because
Yeah.
the same issue is going to come up. Should you have centralized care coordination, or is it right to try to link the care coordinators out to the practices on the community?
Well, right now we're doing this in an ACO population for the first time in the Medicaid RECOs. And there, the motivation might be slightly different. We're thinking those practices may be more interested in being involved if we can increase their key performance indicator, which is child care, not immunizations, but they should go hand in hand. So we're going to have an interesting experiment there, because I think, and the head of the RECO, Marshall Thomas, who is an investigator on this, really wants these, key performance indicators up. So he may, in fact, be able to push practices to do this more. So we'll have a more even, maybe, look at this. Okay, so here's cost. For receiving any vaccine, $13 in the centralized versus $62 in the practice-based. And per child brought up to date, 27 versus 104. For practice, roughly 117 for centralized and 1,100 for practice-based.
This is just cost of recall, not cost of vaccination.
That's right, just recall. So here's the models, both about 1.3 or so, adjusted for lots of different things, for receiving any vaccine and for becoming up to date. So the effective practice endorsement, again, this is not a randomized trial. Different practices chose to endorse, practices that chose to endorse were likely different from those that didn't. So this isn't an entirely even comparison, but it did indeed look like practice name being included had a stronger effect, with an absolute effect difference of 8%. And this was, I think it was roughly 60% of practices endorsed. Is that right, guys? Okay, so at this point, about 60% of practices, this is the 32%, okay? So you might ask, why didn't practices endorse? And here's the same information for up to date. And things they told us were, number one, they weren't actually delivering vaccines to kids, and we couldn't tell that. Their practice was, kaput. But I think the most common reason is they didn't want to be blamed if something went wrong. If somebody was recalled incorrectly, they didn't want it to be coming from them. So, very interesting. So there are obviously limitations to these data. These populations are impossible to accurately denominate, as we discussed in the beginning. Centralized reminder recall was obviously hampered a lot by bad addresses from vital statistics. We had to spend a lot of time and money updating those, and it could be a whole lot cheaper if those were more up to date. If the time frame had been longer than 6 months, maybe more of the practices would have done reminder recall, although I have to say that we've now done a serial of 4 since then, and nobody's doing it. So, and finally, costs were based on personal report rather than direct observation. So overall, although both methods increased immunization rates, the county level centralized reminder recall was more effective and cost-effective, primarily because of the unwillingness of practices to do this or the low reach of the intervention. The cost per practice or per child vaccinated were much lower for the collaborative centralized model, and endorsement by the practice may increase effectiveness, but obviously there's some selection bias possible. Okay, so I was going to go on to show there was another embedded reminder recall that looked at 2 different protocols to do this, and we're actually in the process of looking at some more protocols, but let me explain this one. So this was embedded within the trial I just described, and within the 7 counties in which we did centralized IIS-based reminder recall, we compared cost per contact and marginal cost for autodialer and mail contact types, so between those 2 types. And then we looked at overall effectiveness and cost effectiveness of 2 different protocols, and they were both, or one of them was mixed, consisting of 2 autodialer calls and up to 2 postcards, and the other one was mail only. So you might ask, why did we mix them? Well, we wanted it to be effective, and we knew up front we didn't have phone numbers on a lot of kids. So the number 1 will give you information about what each type actually costs per contact, but number 2 actually compares the protocols. Okay, once again, the populations were exactly the same from these 7 counties. And so I actually won't go over this again because basically it's just the same. But here's the randomization. So these were all eligible children in 7 counties. They were randomized at the level of the patient. Okay, so this is within each practice, they're randomized at the level of the patient to autodialer mail or to mail only. Those in the autodialer mail group that did not have a phone number went to the mail portion. And those with a phone number got a couple of autodialers and then mail. So we were trying to maximize effectiveness but decrease cost. I'm not going to go into these statistics. They're about the same. So the cost assessment was from the perspective of the state public health department. And we looked at costs directly related to implementation, not startup costs. Okay? And they included staff time related to identifying patients to contact and creating the messages. The supplies needed, printing and postage, prorated. We included a prorated cost for the autodialer software. You could do that in a lot of different ways. If you're interested, we can talk about it. But we chose to actually buy a machine because we had so many people, and then to, amortize it as a fixed cost. And then we looked at staff time related to updating bad patient contact information, phone, and mailing addresses. So the cost per contact was first calculated for both types of ReminderRecal, either autodialer or mail, and marginal costs were calculated, which is the additional variable cost associated with one more contact for each type, so it does not include the fixed costs. And I'm not a health economist, so this is pretty basic. I think I can even explain it. All right, then we looked at total cost per protocol. And to do that, we took the number of contacts in each arm times the relevant cost per contact type, and we used an intention to treat analysis. Nobody changed over between arms. We also looked at cost effectiveness per protocol. So that is the total cost for each protocol divided by the outcomes our major outcomes: cost per child, cost for any immunization received, and cost per child brought up to date. Okay, so first of all, autodialer versus mail cost. This is the total costs for each type of, I should have a pointer. For each type of, here we go, contact. So obviously overall, autodialer costs were way lower than mail costs, but of course a lot of people never got the autodialer because they didn't have a phone, okay? But these are the components that went into that calculation. And you can see that the biggest component, obviously, for the mail is printing and postage. And for the autodialer the autodialer itself was probably the biggest cost, and updating phone mails was an appreciable cost, although much higher in the mail. Okay, so this is the cost of doing an autodialer versus mail. 53 cents for autodialer, 73 cents for mail, the difference of 20 cents. And this is the marginal cost. So that's, if you start now, you got the system up and running, no fixed cost, it'll cost you 15 cents to do one more autodialer. It'll cost you 68 cents to do one more mail. So clearly, autodialer is cheaper, and it could be cheaper than this probably if you used a different method, but this is the method we used. Okay, effectiveness. Now, what happened here? There were about 9,000 kids in these arms that were not up to date. Half of them were randomized to each group. Of the autodialer mail group, 42% had no phone number. So you can see that if you had only done autodialer, you wouldn't have been able to reach any of those kids. So that's why we did choose to do a mixed protocol. And that percentage went directly to mail then. These kids got 2 autodialers and then went to mail, and these kids got mail only. So I've carried these out to 2 decimal places because I didn't think you would believe how exactly the same they were in terms of effectiveness, which is, I had Brenda check these numbers I don't know how many times. So this is the percentage receiving any vaccine in these 2 protocols, 27%. This is the percent brought up to date. I mean, they were identical. So the cost effectiveness, this is the number of any contact in the 2 arms, 3.4 versus 3.2. And mail contacts were still pretty high in the autodialer mail group. If this is 2.3 on average, 3.2 in the mail only. Okay, so the autodialer mail group got a lot of mail contacts as well, which is why it was relatively expensive compared to autodialer would be alone. Okay, and this is the cost effectiveness comparison. Cost per child, $2.24 versus $2.31. Cost for receiving any vaccine, $8.31 versus $8.71. and per child brought up to date 1738 versus 1843. So not as dramatic a difference as we might have seen if we didn't have so many of the auto-dialer mail kids getting mail. So we had lots of statistical power. Because we were able to randomize at the patient level, this decreased a lot of potential sources of bias relating to clustering within practices or geographic areas. However, costs were based on personnel report rather than direct observation, and the fact that we had mixed protocols to maximize effectiveness made this a little bit less clean in terms of directly comparing. But we can, from these data, estimate what auto-dialer and mail can do alone. And what we're doing right now, actually, is we're stepping this down each time. We're in our last cycle now, and we will have 4 consecutive cycles in the same age kids, each time decreasing the amount of effort we're putting into, for example, updating addresses and the number of contacts we're making. The last cycle that we're doing right now is 1 contact by mail versus 1 contact by auto-dialer. So we'll be able to see with each decrease how much bang for your buck you're getting, and if you're a state public health department, what you want to invest in. So these protocols were exactly effective, but the auto-dialer mail was a little bit less expensive. Obviously, if you could dial down the mail, it would be much less expensive, and if accuracy and completeness of the phone information in the IIS were much higher, for example, as HL7 compatibility goes up and you've got automatic feeds going into the IIS, this could be really cheap, and it could be generalized to other preventive care services. Any questions about that? David?
Just an observation that rate of, just based on like clinic experience here, the rate of no phones seems really high. And I'm guessing that's because the database doesn't get updated for that information very often. So it would seem to me that that's one of those places where the collaboration that you talked about in the beginning could really up your, decrease costs for the entire system if you were able to make that work.
Yeah. Well, and there were a fair amount of practices that did do that. But some of those practices aren't very good at updating their phone numbers, for example. And right now I think is it about 50% that can do that, either by flat file or HL7? I mean, there's a lot of practices that are not there yet. So then we had to go to them and say, do you have another, manually, do you have another phone number in your database? So you know more than I.
It's in the same area. You had a much lower cost to update the phone numbers. What percent of the phone numbers were bad? And do you know the reason why? They mentioned the practices might have it not sending it. Was this the phone number when the kid was born?
It could be.
So is there what did you learn about how to update the phone number? Because it seems like if you could update the phone numbers, that would be the best way. You get more bang for your buck, cost less money.
Right.
You don't need to be dealing with addresses which are more complex than phone numbers.
Well, what's supposed to happen is that when a child gets an immunization, their administrative data should upload. But what we're seeing in reality is that is kind of variable. And it kind of depends on what the practice has worked out with the IIS. And so that is the best way for this to happen. The other thing that would be better is, why do you have to wait for an immunization to be given? Why can't this administrative data be regularly updated? Because there's big gaps between the times that kids get immunizations. But that's not a capability that the IIS has right now. So I can't absolutely tell you why it's low, except that it is. Yes, Dan.
Allison didn't quite go into the population and their healthcare habits, but just in terms of the phones, we see that in the schools all the time. People are moving away from one home phone to cell phones, and they switch phones, depending if they purchase it for a
Brenda, can you comment on whether they allow multiple fields in CIS for phone?
They do. They actually have 4 fields. They have a home, a work, a cell number, and a pager. What I can tell you is that cell phone is, I'm going to say, less than 5% populated. Home phone is the most populated at this point. I'm assuming that's because that's what they get at vital stats. We do have some work numbers, and if they didn't have a phone number, we use the work number.
But, part of this, it could definitely be streamlined if practices and CIS were working together, and the practices that, okay, well, we're going to uniformly collect, they told their patients, we're going to uniformly collect, your home phone and your cell phone if you'll allow us to, and, there could be a lot more collaboration, and this could be done much better. I mean, I think the IT is definitely part of the problem. The fact that so many practices still cannot interface electronically with CIS.
I think the schools run into the same problems because when they have like a healthcare emergency or something like that, sometimes they'll call and the phone number's different or they don't have the correct information. So it's kind of a reflection on the way people do things and
Yeah.
answer questions. Because if the question asks you for a home phone, then you give the home phone. If it asks for a cell phone, then it sounds like you were trying to complete half the cycles. If you did your contacting, if you couldn't get them by home, and then you tried cell, that'd be like contact number 2.
Yeah. I mean, of course, we didn't have any control over what they had collected. If you did this prospectively, we're currently doing a project in Kaiser where we're giving parents the preference of how they like to be recalled between, auto dialer, email versus text. And I think that's pretty important because if we see a whole lot better response, if we pay attention to what they want, I think that's going to be an important lesson. Because, they may not respond to whatever method they chose.
What's the distribution so far between those 3?
Well, we don't have outcomes.
Oh.
I just presented at PAS. Interesting, in Kaiser, the overwhelming preference is for text, which is quite different from other populations we've looked at. And that may be because Kaiser patients are used to the email interface, or they're higher tech, they definitely are a little higher SES. And within the Kaiser population, Hispanic populations were much more interested in text, which, you've seen in a lot of different populations. But I was surprised. It was like 2/3 preferred text. So that's interesting. Now, this was specifically for HPV. So these are parents of adolescents.
Whose kids are not up to date.
Whose kids are not up to date, and 80% of them did not want the children to be reminded, 20% of them did, in addition to themselves. So that was kind of interesting. Okay, so we're not going to have time to go through everything I have here, but I wanted to give you at least a little flavor of how acceptable is this kind of approach to providers and families. So we did a survey. We actually did both qualitative work and quantitative work, but I'm just going to talk about the survey. We did a survey of all primary care providers from the 14 counties that this trial was in, and we had about a 74% response rate. We did incentivize them with some monies. 56% of the provider in the centralized counties were aware of it. Okay, so only a little over half of providers were even aware that this happened, even though we told them it did. And that's the distribution by specialty. Wait a minute. Excuse me. I'm sorry, this is out of order. I think we have the wrong slide here. Oh, wait. So I'm going to talk first about parents, okay? So within the counties where there was centralized ReminderRecal, we did a stratified random sample of parents who, and we actually oversampled in rural areas rather than urban so that we'd be able to make those kind of comparisons. We sent out a pre-letter 4 weeks prior to the survey and then did a paper-based self-administered survey. and a reminder postcard a few days after that, and up to 3 additional mail surveys. $5 was included in the first and the fourth survey. The response rate for this one was 55. Most of these parents were female, and their educational status is shown here. About 30% had high school education or less, 28% had some college, and 44% were college graduates or higher. The children's insurance was 54% private, 41% public, and 5% had no insurance. So sort of a balanced group. So these are some attitudes about the sources of ReminderRecal. So about 90% supported the health department sending reminders to children who needed shots. 58% strongly agreed with that. About 50% felt that it was their child's doctor who was responsible for making sure the child got their shots. About 19% strongly agreed with that. About 40% were not sure whether it was a good use of public money for the health department to send reminders to parents about the child's shots, and 15% felt strongly about that, and 39% agreed that it was the health department's responsibility to make sure their child got shots. About 10% felt strongly about that. So sort of mixed feelings in terms of whose responsibility it is, with more people being in favor of it being the child's doctor. The majority felt that their doctor did a good job of reminding them when their child needed shots. 70% overall think it's okay for their doctor to share information with the health department about their child as long as it is confidential, and 26% agreed strongly with that. And I think this is kind of an interesting one. I don't think my doctor or the health department should remind me when my child needs a shot. About 20% agreed with that, and 7% strongly. The one I wanted to highlight here. Okay, so the middle one, if I had a choice, I would prefer to get a reminder from my child's doctor than from the health department. About 80% agreed with that, 44% strongly, and 55% overall agreed that they'd be more likely to get shots for my child if I was reminded by the doctor rather than the health department, 24% strongly. Now, then we asked them overall, if your child needs a shot, who would you like to contact you? And here it's interesting because despite the fact that we've heard some contradictory stuff, 40% say the child's doctor, whereas 50% say either my doctor or the public health department. Only 4% say the health department, and 7% don't think parents should be reminded about immunization. So if you had to choose one location, it would be the doctor's office. But as you can see, a slightly higher percentage of parents really don't mind if the health department does this. Now, this was prior to collaboration. So this was just the public health department sending it out without the doctor's involvement. We're currently repeating this now after doing the collaborative approach and trying to get answers about how do parents or providers perceive this when it has the doctor's name on it. So it seems to be coming from both the doctor and the health department. And here's just, I alluded to, we got some pretty different answers, and this was a couple of years ago, but as you can see, overwhelmingly, preferences for reminder method were male in the population. So different strokes for different folks. Yeah.
Of course, correct me if I'm wrong, when you were talking about the Kaiser stuff that you referred to just earlier, there was no choice of a male. It was.
That's right. You're absolutely right.
So I guess.
Email, text, or autodial. You're right, because Kaiser said, no, we're not doing that.
I wonder what this was.
Yeah, you're absolutely right.
We're not going to spend money on mail, which
That's right. I have to say, though, we've done some since then, and mail is decreasing a lot. It seems to be, and other national surveys show that as well. I think text is going to be, where we're going. But Okay, so here's the provider. I'm sorry that one slide was out of order. So here's the 74% response rate, and the respondent was self-identified as the person who makes policy decisions about immunization delivery at the practice. So here's sort of similar results than we saw from patients from providers. It costs too much money for us to conduct reminder recall. About 59% agreed with that, 16% strongly. I would prefer to conduct reminder recall for patients, 43%, 12% felt strongly about that, and about half thought it was not feasible to do practice-based reminder recall, 13% felt strongly about that. This is an important one, I think. I would be bothered if the health department conducted reminder recall. Only 15% were bothered, 5% were strongly bothered. So that we thought was pretty good. And again, this is just about health department versus provider. It is not about the collaboration. I believe population-based reminder recall might help patients without a usual source of care was pretty universally accepted. And 67% agreed that population-based reminder recall is the best way to reach the most people. So 128 surveyed practices said that they remembered having centralized reminder recall. 128 were involved. 56% of those remembered being involved. Most, 80% or so, did not report any parents being upset, but 20% said some parents were upset. 67 reported that reminder recalls did not result in a high volume of patients. That was one of the concerns a lot of people had. And unfortunately, it's not that successful, so you don't have a high volume of patients, but that was one of their concerns. And about close to half reported that at least some patients expressed confusion. So this was one of the reasons we did the second round with the collaborative approach. And then finally, when asked to take into account feasibility, financial issues, privacy issues, and belief about provider responsibility, the providers looked actually pretty similar to the patients. About 51% thought the health department should do it. Now that's not an either or here. It's the health department. It's a little different. 46% thought the practice should, and 3% thought parents should not be reminded. Of those who wanted the health department to do it, we then asked them, do you want the letter to come from the health department? Do you want any involvement in this or not? And you can see the breakdown there. About 15% wanted their name on there at that time. 20% wanted the letter to come from the health department. 16% wanted no involvement of any type. But I tell you what has happened since then is practices are more and more interested in doing this. In fact, we're having trouble getting them to agree to being randomized to practice-based intervention. So I think we'll stop there because and see if you have any questions or discussion. Yes, Dan.
Another one, taking a step back, looking at the communication. I know in the days when kids being immunized, you generally followed the instruction of when to come back next. Nobody really gave you a roadmap, in terms of saying, this is due here and here. And every year I give the updates, there's changes in terms of new immunizations. It's kind of gone from a few to many. And is part of the problem just parents really don't know when things are due at what time, and then if they don't get regular follow-up, things kind of fall through.
I think that's part of it. Absolutely. The complexity has gone up astronomically. So it's not just, it's hard even for providers to figure out when the next visit is. I mean, usually when you leave the office, you get some advice about when to come back, even if you don't understand when your next set of immunization is. But if you're not getting regular care or you fall off the grid, yeah, it's very complicated.
These kind of, summaries come often through kind of pediatrics once a year. Here's kind of the new philosophy of when
although I don't know, but that might be worse, because then you'd have
Yeah,
people going, oh my God, how many vaccines are I supposed to get at 1 year vaccine?
that's my usual reaction.
Yeah. Yeah, it's very complicated, and I think the more we have systems to take care of some of the complexity, the more successful we're going to be. The final comment is, reminder recall is not the be-all, end-all. It's step one, of a complicated group of interventions that you have to institute. It's just the low-hanging fruit. It is not going to solve the problem, but it is going to solve the problem quickest for the largest numbers on a population-based level. And then you have to do the second step, which is, why aren't those people responding? And you have to do tailored messaging, you need to do, marketing and communication, that kind of thing, and outreach.
That had, when you saw the complaints, how many of them were, they got called by the health department that they already had the immunization?
A lot. Yeah, they got a postcard and this is based on people's recollection. So I think, they tend to recall if there was anything that went wrong. And, parents would sometimes say, hey, I was just there 2 weeks ago, how come you don't know about this? And then the provider, and the letters and postcards, as we've gone along, we've gotten better at making sure it's very clear that this is according to the state immunization registry. Call your office and make sure it's correct, kind of thing. But most of it is that. I remember one person who went all the way to me, who was a lawyer, who wanted, which is kind of interesting because you would think she would know about the fact that the immunization registry in this state is an opt-out. I mean, her practice has to say that they're involved in the immunization registry and they can opt out. But she was curious that the IIS had her name, wanted to know how that happened. But, that's exceedingly rare.
Did that call go?
What?
How did that phone call go?
Well, it was really easy because I could just speak law to her. It's like, this is the public health department does have the right. There's a specific statute that says public health department can do reminder recall using the registry. So in fact, you don't need permission. They don't need permission to do this, but obviously it's much better if it's collaboration with primary care, so they don't feel, undercut or whatever. Okay, great. Thank you guys for coming.